So you must be wondering what is our aim to be here? Why are we gathered here, right? So our aim is to help MRCOG students to ace their exam in one go. But how? How can we do that in the span of only 2 months? So I think this question is in every student's mind. Oh, hi, Dr. Sumbal. How are you doing?
Hello, I'm fine. How are you?
I'm doing great. So you must be receiving such questions every day, don't you think? You can answer these questions better from your experience?
Yes, exactly. I have already receiving so many questions from the students, and they are really confused about how they can start the exam preparation and how they can pass the exam in one go. So many students think they can start the exam preparation after the booking, and honestly, many people did that. Am I right, everyone? Please write in the chat box. How many of you have already started the exam preparation?
Dr. Sumbal, could you please speak a little louder? We can't really hear you properly.
Yeah, sure. What I was saying is that so many students think they can start the exam preparation after the booking, and many people did that. So I was asking everyone, is that the case with you, everyone? Please do let me know how many of you have already started the exam preparation.
Can I speak?
Yeah, sure.
Yes, I start my preparation. Even I don't booking for next July exam because I'm too late for booking. So my exam, I guess, will be in next January, inshallah. But by anyhow, I start preparation nowadays. Is it okay?
Yeah, you did the right thing. And honestly, that's a very smart approach because we all are doctors and we have busy schedules. So it's a wise thing if you started your exam preparation by now. I really appreciate that.
Thank you.
You're welcome.
Let's address the January students at the end of the session, but let's try to have the students who are appearing in the July, the ones who have less time.
Yes, definitely. So what I recommend to our students, first of all, don't mess your minds with books at this point because you have very limited time to sit in the July exam. So what I recommend, just grab the recorded lectures which we have already prepared from different resources and gather all the important knowledge there. So what I'm trying to say is use these 60 days by watching already prepared lectures by our team. You may practice recalls on our website. And most importantly, you can practice those SPAs with me on Telegram group. And after that, I will conduct a mock so that I shall know where do my students stand in terms of the exam preparation. And according to that, I will provide them the feedback and I will work on you all. Am I clear?
Yes, ma'am.
Yes, ma'am.
Yes, ma'am. You are clear.
Okay, that's good.
So, ma'am, you mean that they don't have to open the books? They can just watch the lectures and they will be done with the concepts. Is that what you're trying to say?
Yeah, definitely. Because we have our currently going a premium session in which we primarily worked on our students and we help them to build their foundations because in the MRCG1 Part 1 curriculum, we have all the basic subjects and those subjects require very clear concepts. One must have crystal clear concepts on those subjects. So in our recorded lectures and we have the PDFs, we particularly highlight those points which would help you to pass the exam and also meanwhile they clear your all the concepts regarding your basic subjects.
That's wonderful. So Dr. Sumbal is telling you guys that you just need to listen to the lectures and just practice the recalls, and then you will have the chance to pass the exam in one go.
Everyone's in the party.
Okay, Dr. Sumbal, we have our premium students as well here, as they don't want to miss any of your important lectures. And so why don't we take their feedback as well?
Yeah, that seems a nice idea. We can do that.
So anyone from our students who have done half of their preparation and they would like to share and guide other students, how is their journey with us so far? So we have Dr. Sana, Dr. Noor, Dr. Ruby, Dr. Paul, Dr. Saima as well, and Dr. Alia. So who's with us?
Uh, can I speak, ma'am?
Sure, ma'am.
Actually, ma'am, I'm taking your class on the WhatsApp group for SBS, and these are really amazing. And you people are very good with us, and you reply to us within minutes, and that's amazing. I really appreciate this thing of you, you all, and. I'm totally satisfied with your lectures, with your exam preparation. Thank you.
Hi, ma'am. Can I speak? Am I audible?
Sure. Yes, yes, you are.
Okay. I'm Dr. Sana. I'm from your premium group. I'll be really honest with my opinion. I'm really grateful to join this course, as everyone in this Medin's tutor family is really helpful and motivating, and they are always available to guide and support and help and motivate in every way possible. So I'm really grateful and I'm really happy to join this course. And more of, if in person I wouldn't have joined this course, I wouldn't be able to book my seat in the first place. So I'm really thankful to Dr. Minhal, Dr. Sumbal, Dr. Sadia. Like, everyone in this group is so helpful and so motivating. So yeah, it's the best.
Thank you so much for your kind words. We really appreciate that. Thank you so much. So, Dr. Ruby, would you like to share your experience? Like, how's your preparation now, and how Med Institutes, Dr. Sumbal, and the backend team help you from booking your exam and prepare for your exam? Anyone from the premium students? Dr. Bridget, we have Dr. Bridget, we have Dr. Bhavna, we have Dr. Noor as well. Would you like to share your experience with other students?
All right. Hello, everyone. This is Bridget. I'm grateful to the group and our tutors who have been supportive in answering questions and preparing us for daily sessions where we answer questions, and I'm really grateful. I'm still preparing, and with the work, it's kind of sometimes hard. Sometimes I miss the lectures, but thank you, because we usually get access to the recordings, and it has really been helpful. And I am looking forward as Bridget to acing this exam in my first attempt. So I just wish all of you the best. I pray that we continue to work as a team and work harder. Thank you. Bye.
Thank you so much for your feedback. Let's just start our session now, and we will take the other students' feedback at the end of the session. All right. So Dr. Sumbal, you may start now.
Okay, today we are going to start our first module, which is anatomy, and this is a very important subject for the exam. What I'm going to do today, I will start with an overview and I will break down each region's SPS into abdomen, pelvis, and perineum, which would help you to stay organized and well prepared. So let's start with an overview of anatomy of abdomen and its SPS. Okay, it's a brief overview of interior abdominal wall. When we look at the abdominal wall, particularly interior abdominal wall, we have different layers. Try to remember the sequence, how each layer is there on the interior abdominal wall. So initially we have the skin, which is the outermost layer of the abdominal wall. Below the skin, we have subcutaneous tissue, and this subcutaneous tissue is further divided into superficial campus fascia and deeper scarpus fascia. Here you can see in the diagram, this is the first and the outermost layer, skin, and then we have the campus fascia and the scarpus fascia. Following that, this is the symmetry throughout our body, that we have skin tissues, we have fascia, and below fascia we have muscles. So what are the muscles of the interior abdominal wall? The main muscles include external oblique muscle, internal oblique muscle, and transversus abdominis muscle. And following these muscles, then we have another layer of fascia, which is fascia transversalis. Below the transversalis fascia, there is finally parietal peritoneum. And why we are starting with the layers of abdominal wall? The answer to this is that in the obs and gynae, we do many surgeries on the abdomen, and we do give the incision to the patient. So it's important that you are well oriented about which layers of the abdominal wall you are going to incise during the surgery. And what is significant from the exam point of view, sometimes you might encounter with any SBA in which they ask you about the correct sequence of the layers of the interior abdominal wall. So again, try to remember in the sequence from the outermost layer to the innermost layer. And sometimes what they do, they reverse the order just to make you confused. What they do, they ask you in the question that arrange the following layers from inside to outside. Then in that case, you have to reverse the orders, choose the option, and go reverse in the reverse manner, starting from the peritoneum and ending at skin. Here's another tip. Whenever you are solving SPS and when you are writing your exam, make sure you read the question statement carefully and read all the options carefully. What is the normal psychology of the students? What they do, they just quickly read the SPA and they feel somehow overconfident that this is a very simple question, I knew the answer, and they rush and go with the wrong answer. So always read your statement carefully and read the options carefully. So what is the function of anterior abdominal wall? It protects your internal abdominal organs, it stabilizes your trunk, it helps to increase your intra-abdominal pressure, for example, during coughing, defecating, or vomiting. So what are the muscles of anterolateral abdominal wall? So we have 5 key muscles. Again, number 1, transversus abdominis muscle, internal abdominal oblique muscle, rectus abdominis muscle, external abdominal oblique muscle, and finally pyramidalis muscle. So here in the diagram, you can see all of the muscles of the anterolateral wall. Here is the rectus abdominis muscle. Here is this one is the internal abdominal oblique muscle. Here in the transverse, why these names are given to these muscles? Because it is according to the arrangement of their fibers. So it's very evident the transversus abdominis muscles have transverse muscle fibers. Then internal oblique muscle have the fibers which are moving upward. In this diagram, the external oblique muscle is not shown. However, the fibers of the external oblique muscle are moving downwards. It's just like you are putting your hands in your pockets. So it's moved that direction, the fibers of the external oblique muscle. There is a mnemonic to remember the names of these muscles, which is diaphragm. T stands for transversus abdominis, I for internal abdominal oblique, R for rectus abdominis, and E for external abdominal oblique muscle. And finally, P stands for pyramidalis muscle. Before we move further, a quick reminder, our Power Hour course is now available at a discounted price for the next 24 hours only. So don't miss out on this opportunity. You are getting our course in just rupees $125. Let me outline the courses we offer and what they include. Currently, we are offering two courses. One is a comprehensive course, and the other one is the Power Hour course. In comprehensive course, you will get organized schedule under the guidance of RCOG examiner. You will get mini schedule of all the subjects, interactive live sessions, recording of all the sessions. You may get comprehensive notes, which are available in the PDF form. We have intensive 2 hours of daily discussion and SBA practice with the mentors. We have subject-wise solved recalls, which are available on our website. Again, we have year-wise recalls, which are also available on our website. We have all the books and supplementary material, which are all of these things are there only under one platform. All you have to do is just to log in, go in the comprehensive course, and there you find all of the material which is which you need to pass the exam. Then we have we arrange mock after every subject on our website. Then we have the other course, which is Power Hour course. It is also a structured course, which is guided by RCOG examiners. In this particular course, we have interactive live sessions, which are subject-wise. We have recording of all the sessions. We have daily 2-hour recall practice with mentors, subject-wise recall practice, year-wise recall practice, and you may have access to all our SBA pool. And after each module, we again arrange a mock test for you after each subject. And once you are done with the subject-wise mock exams, then final we have 3 big mocks for you. And trust me, that's all you need to pass this exam with a structured approach. Because if you follow this pattern, you will revise all the SBAs a minimum of 3 times. If you do that, because revision is the key to pass this exam, if you thoroughly practice SBAs and do maximum revision a minimum of 3 times, then nothing can stop to pass you this exam. So let's get back to the anatomy of abdomen. This is a topic which many of you frequently confuse, like many of you find difficult to remember the level of vertebra of each artery of the abdominal aorta. So let me give you a brief. At the level of T12, we know from where this abdominal aorta is coming from. This is basically, we have left ventricle, which pumps out all the blood through the system into the systemic circulation. And this abdominal aorta is a part of your systematic circulation. So what happens at the level of T12 vertebra? In a simple way, if you remember, at the end of your thoracic cavity, and we know the final thoracic vertebra is T12. So at that level, our abdominal aorta begins. So it is very easy to remember the level of T12, which is the end of our thoracic cavity and the beginning of the abdominal cavity. marks the origin of celiac trunk. So T12 vertebral level stands for the origin of celiac artery from the abdominal aorta. If you remember in the sequence, then you will never forget the vertebral levels. So relate everything. Celiac trunk is the first branch of the abdominal aorta, which originates at the level of T12. If we move downward, now imagine you are moving into the abdominal cavity from upwards to downward direction. And remember what viscera and what structures come in your way when you are understanding the blood supply of the abdomen. So we are done with the celiac trunk. The celiac trunk is mainly responsible for the blood supply of your foregut. So now you are done with the blood supply of the foregut, which includes your liver, your stomach, your spleen, and your pancreas. Then we have our next artery. The next branch of abdominal aorta is the superior mesenteric artery. Now imagine after foregut, what would come, what structure would come into your mind? That's your midgut. And the next artery is superior mesenteric artery. So superior mesenteric artery is the blood supply for your midgut. And now we are done with T12. We are moving forward, downward. Now, what would be the next vertebra? L1. So superior mesenteric artery originates at the level of L1. The next structure we have are two structures. We have two kidneys and we have gonads. In the female, we have ovaries. So at the level of L2, the artery, the branch of the abdominal aorta is the gonadal artery and the renal artery. So classically, renal artery comes from the intervertebral disc level, which is somewhere from the lower border of L1 and the upper border of L2. However, the gonadal artery originates at the level of L2. Now we are done with the, I'm summarizing again so that you can remember now. T12, end of thoracic cavity, beginning of the abdominal cavity. T12, celiac trunk, done. Then we have, following our foregut, we have our midgut. The next artery is superior mesenteric artery at the level of L1. Following that, we have our kidneys, and we have gonads. The renal artery comes from the level of lower border of L1 and upper border of L2. Gonadal artery comes from the level of L2. And once we are done with L2, now comes downward. Now we have our hindgut. And the blood supply to the hindgut is through inferior mesenteric artery, which is the branch originates at the level of L3. Now moving downwards, we have the terminal branch of the abdominal aorta, which is median sacral artery. It is the last branch of the abdominal aorta, and it originates at the level of L4. Meanwhile, L4 holds other significance as well, because at the level of L4, this abdominal aorta bifurcates into right and left common iliac arteries. Further, if we move downwards to the L5 level, now what happens? This common iliac artery further divides into external and internal iliac artery. So the landmark for the internal and external iliac artery bifurcation is to L5 to S1. So remember, many of you confuse that. Once you find the key word in the SBA, that bifurcation of aorta, you quickly jumped on the L4 level. Please again try to read the statement carefully. Either they are asking about the bifurcation of common iliac artery, or are they asking about the bifurcation of abdominal aorta? So these two terms are different. So make sure to read that again and mark accordingly. L4 for abdominal aorta bifurcation and L5 to S1 for common iliac artery bifurcation into internal and external iliac artery. Am I clear so far?
Yes, ma'am.
If you have any question, you can ask me in the chat box, and I always encourage my students to open their mic and they can ask the questions directly. Okay, so if you understand the arterial supply, that would become very easier for you to understand the venous drainage of the abdomen, because all the arteries, all the veins and their tributaries are, according to their arterial supply, they have the same name, only with a few exceptions. Okay, let's start. Whenever you are understanding about the arterial supply, try to start from the heart. And whenever you are understanding or reading the topic of venous drainage, try to start from the bottom line, in a simple way. Understand the flow of blood towards the heart, and when it comes to the arterial, try to understand the flow of the blood away from the heart. So now we are going towards the heart. For that, we have to start from the below. You can see here the internal iliac veins and external iliac veins. They are draining into common iliac veins. And these common iliac veins are directly go into the inferior vena cava. The exception here is that when you look at the left side, the left ovarian or testicular vein drains into the left renal vein, whereas right ovarian or testicular drains into inferior vena cava. Here you can see in the right side, this is right gonadal artery. Either it could be ovarian or testicular. You can see here it is directly giving tributary to the inferior vena cava. But when you see on the left side, it is very, very obvious the left gonadal artery is draining into left renal vein instead of inferior vena cava directly. So what it do, it will give tributary to the left renal vein, and this left renal vein would drain into inferior vena cava. So this is the difference. Try to remember again the difference between right and the left venous drainage of the abdominal wall or the abdomen. Now let's understand about the peripheral nervous system. So peripheral nervous system is mainly formed by the spinal nerves. There are total 31 pairs of spinal nerves in our body. We have 8 pairs of cervical nerve, 8 pairs. We have 12 pairs thoracic spinal nerves. Then we have 5 pairs of lumbar. Then we have 5 pairs of sacral and 1 pair of coccygeal. And all these spinal nerves, all these 31 pairs of nerves, form different plexes in our body in order to make the peripheral nervous system. So what are the main 4 plexes? C1 to C4 combine to form cervical plexus, which is the main plexus of our head and neck. Then we have the brachial plexus, which starts from C5 to T1, which is the main innervation of our upper limb. Then L1 and L4 and a few fibers from the T12 combine to form lumbar plexus. And following that, from the L4 to S4 combines to form sacral plexus. Yes, Dr. Hayal, you may ask your question.
Assalamu alaikum, ma'am. Assalamu alaikum, everyone. Actually, I just want to give a little feedback regarding your theory course.
Yeah,
can I
definitely.
give it now or later on? Hello?
Yeah, you can give your feedback.
Actually, I am from a regular theory course of Med Institutors. And as today is, I think, recall session for recalls. Actually, I want to say thank you, first of all, to Med Institutors and especially Dr. Minhal, because he is every time available. The good point for your team and Dr. Minhal is that she is every time available, whether it is on group or it is on her private number. She is every time available, and whole team and ma'am especially have a quick response every time. And the other thing is that especially your lectures, ma'am Sumbal, are very much interesting and full of knowledge. And I don't think if I am doing your lectures especially and with full interest, with full concentration, then I don't think that there will be any SPA in the paper that will come out from it. So thank you for making so much efforts for us. Thank you so much, ma'am.
Thank you.
Thank you.
Okay, so we were talking about the peripheral nervous system. So now let me summarize. We have cervical plexus, brachial plexus, lumbar plexus, and sacral plexus. For the MRCOG1 exam point of view, we have important plexus are lumbar plexus and sacral plexus. So let's have a look at lumbar plexus. The spinal nerves from T12 to L4 forms the lumbar plexus, and here are the main branches. We have iliohypogastric nerve, ilioinguinal nerve, genitofemoral nerve, lateral cutaneous nerve of thigh. We have femoral nerve and obturator nerve. And here is a mnemonic to remember that. It's a very easy mnemonic. I get leftovers on Fridays. I stands for iliohypogastric. Another I stands for ilioinguinal. Then we have genitofemoral. L stands for lateral cutaneous nerve of thigh. O stands for obturator nerve, and S stands for femoral nerve. Your task is to remember the root values. Iliohypogastric nerve, as you can see here, it is mainly coming from the L1, and meanwhile, it is receiving some fibers from the T12 level as well. However, the main root value is the L1. Ilioinguinal nerve, it is coming from the L1 level. Then we have the genitofemoral nerve. It is sharing the fibers from the L1 and L2. Lateral cutaneous nerve of thigh, it is receiving the fibers from the L2 and the L3 level. Femoral and obturator nerve are both come from the L2, L3, and L4 levels. So this is the summary. Try to remember each and every root values of all the nerves of lumbar plexus. Then we have the sacral plexus. It is a network of nerves which formed by the lumbosacral trunk, L4, L5, and sacral spinal nerves S1 to S4. In the sacral plexus, we have superior gluteal nerve, inferior gluteal nerve, sciatic nerve. This sciatic nerve further divides into tibial portion and common fibular portion, which is also known as common peroneal nerve. Then we have posterior femoral cutaneous nerve, pudendal nerve, and some other branches like nerve to piriformis, nerve to obturator internus, and nerve to quadratus femoris. So the root value of superior gluteal nerve is L4, L5, and S1. Then inferior gluteal nerve have root value L5, S1, and S2. Together they give inferior gluteal nerve. Then we have sciatic nerve. Sciatic nerve carries fiber from all of the root values, which is L4, L5, S1, 2, and 3. And now look at the difference between tibial portion, common fibular portion. The tibial portion have all the root values, L4 to S3, whereas in common fibular portion, S3 is not there. So make sure when you are marking any SPA, make sure you exclude the S3 from the, if you are going to choose common peroneal nerve or common fibular portion, then you need to exclude S3 from the root value. Then the posterior femoral cutaneous nerve, it comes from the S1, 2, and 3. And pudendal nerve, this is very important and frequently asked in the exam about the root value of pudendal nerve. They ask you this about this nerve through various ways. So remember S2, S3, and S4. Dermatomes are the areas of the skin, each of which is connected to a single spinal nerve. Together, these areas create a surface map of the body. Here's this is how they have made a surface map on the body, and here's the key of these areas. So for the exam point of view, in the RCOG curriculum, they have clearly mentioned about the topics which they are expecting from you on the exam day. So they mainly focus on the anatomy of abdomen, pelvis, and perineum. So mainly we will get questions from each of the segment from these particular regions. So now let's have a look what are important dermatomes we have. Remember T10, which is level of umbilicus. Here you can see on the body map T10, and I think many of you already knew this dermatome. Then we have T12, which is for inguinal or groin region. And what else we have? S2, S3, and S4 for the perineum. So remember these map keys. S2, S3, S4 for perineum, T10 for the umbilicus, T12 for inguinal or groin regions. And sometimes they do ask about the level of nipples, that is T4. So these dermatomes are important, just memorize them. Now let's start our SPA practice from the abdomen. Question 1. While performing laparoscopy, the lateral umbilical folds can be seen on the interior abdominal wall in the adult. This structure contains option A, inferior epigastric vessel, B, obturator vessel, C is again obturator vessel, D, obliterated umbilical arteries, E, ovarian vessels. You have 60 seconds to answer this question. Okay, well done. Option A, inferior epigastric vessel is the right answer. So the lateral umbilical folds are bilateral raised ridges of the parietal peritoneum in the deep aspect of the interior abdominal wall, overlying the inferior epigastric vessels. Let me show you from the diagram. Here you can see the lateral umbilical fold, and below that you can see how it is overlying the inferior epigastric artery and vein as well. So this is the lateral umbilical fold. Similarly, we have the medial umbilical fold and the median umbilical folds. And simply, these folds are formed due to the thickening of the peritoneum. The parietal peritoneum gives rise to the formation of these umbilical folds. Is everyone clear?
Yes, ma'am.
Which vessel can possibly be injured in the subcutaneous tissue when a transverse suprapubic skin incision is made? Okay, so we have variety of answers. Many of you choose E, A, and D. The answer is A, superficial epigastric artery. It is a branch of femoral artery and runs obliquely upwards and medially across the lower abdomen. It supplies blood to the skin, subcutaneous tissue of the lower abdominal wall below the umbilicus. The artery can be encountered during a transverse suprapubic skin incision. Here you can see this is the transverse suprapubic incision, and this question particularly asks about the blood supply below the umbilical level. So here you can see again how this superficial epigastric artery is supplying the area below the umbilicus, or you can say in the suprapubic region. Is everyone clear who answered E and D? I know why you are confusing with the option C, deep circumflex iliac artery. I have another SPA from the blood supply of anterior abdominal wall. When you see that diagram, then this SPA also make more sense to you. For now, just have a look here, because anatomy is all about visual learning. If you see the diagram, if you know where the structure, where a structure is exactly located, then it would help you to retain more information. So here it is very obvious how superficial epigastric artery is supplying the area below the umbilicus. And here we give the suprapubic incision. Which structure blocks the blood supply to a loop of small intestine in the femoral ring, causing the strangulated femoral hernia? Dr. Bridget, your question is, can this vessel be injured during longitudinal incision too? The blood supply of the anterior abdominal wall is very extensive, and there are many, many landmarks. So we have to study that accordingly, at which part we are giving incision and what artery is present at that area. Arterial supply of the abdomen have regional differences. Okay, B is the correct answer. Excellent, everyone. Well done. Okay, lacunar ligament is the right answer. How it is the right answer? Have a look here. This is the femoral triangle, and here is the lacunar ligament. This one is the lacunar ligament, and what happens? This is the ligament. When we are doing the surgery to repair the femoral hernia, we usually release this ligament to release the pressure on the blood supply of the bowels of the abdomen. So femoral hernias occur when abdominal viscera or omentum pass through the femoral ring and into the potential space of the femoral canal. Strangulation happens when compression of the hernia has compromised the blood supply, leading to the bowel becoming ischemic, and the main artery which is responsible for this ischemia, or you can say the main artery which is compressed during the strangulation, is the inferior epigastric artery. And the lacunar ligament is the only boundary of the femoral canal that can be cut during surgery to release the femoral hernia. Is everyone clear? Here again, you can see how inferior epigastric artery is supplying the bowel. The deep circumflex artery is a branch of which artery? Well done. I'm glad to see so many right answers. This is the right answer. It is a branch of external iliac artery. Again, let me clear you the blood supply of anterior abdominal wall. There are many questions from this topic. So let's have a look. Where is the deep circumflex iliac artery? And it is coming from the external iliac artery. And how here you can see where is the deep circumflex artery in the abdomen. It is at the point of McBurney's point, and this is the artery which is damaged during appendectomy. So make this clear. This is another SBA, which artery is damaged during the appendectomy. So it is deep circumflex iliac artery. You can easily appreciate the anatomical location of this artery. It is at the McBurney's point. So try to connect or correlate the SBS together so that you can remember that till the exam. The next question is the level at which the ovarian artery arises from the abdominal aorta. The level at which the ovarian artery arises from the abdominal aorta. Okay, so the answer is the level L2. I have explained all the branches of the abdominal aorta in the beginning. Many of you have answered that wrong. If you find any confusion, you can again have a look at that slide after the lecture. So the next question is to perform an elective lower segment cesarean section. The obstetrician makes a transverse suprapubic incision. Which of the following abdominal wall layer will not be encountered transected during this incision? Yes, B is the correct answer. Excellent. The posterior rectus sheath is absent below the arcuate line. Here in this diagram, you can see the difference above the arcuate line and difference below the arcuate line. Here you can see there is posterior wall and anterior wall, both are there. There is interior rectus sheath and posterior rectus sheath. While when we see the below the arcuate line, the posterior rectus sheath is absent here. So B is the right answer. Okay, so the next question is which of the following nerves enters the thigh by passing beneath the inguinal ligament, just medial to the interior superior iliac spine? Yes, E is the correct answer. It continues into the anterolateral thigh by passing either below or through the inguinal ligament, emerging just medial to the anterior superior iliac spine and anterior to the sartorius muscle. So here you can see the variants of this nerve. The course of the lateral femoral cutaneous nerve in the region of the anterior superior iliac spine is variable. The nerve can pass over the iliac crest or over the iliac crest or over the inguinal ligament. So don't confuse if they change the word here. Like if they ask beneath the inguinal ligament or over the iliac crest. So make sure this nerve have different variants when it passes through that. So the lateral cutaneous nerve of thigh, and it mainly supplies the lateral cutaneous area of the thigh. So it could pass under the ligament, it could pass over the ligament, over and under the ligament, or over the iliac crest. So all are the variations of the course of lateral cutaneous nerve of thigh. Am I clear?
Yes, you are.
Okay, what is the landmark marks where the external iliac artery becomes a femoral artery? Okay, excellent. Everyone's answer is right. B is the correct answer, inguinal ligament. This is a landmark where external iliac artery becomes a femoral artery. This is inguinal ligament, and below 30 centimeter, it gives rise to femoral artery, which is superficial common femoral artery, which further gives profunda femoral artery and superficial femoral artery. Which of the following arteries may occasionally arise as a branch of the external iliac artery or inferior epigastric artery instead of as a branch of internal iliac artery? Well done. B is the correct answer. Obturator artery is most often an early branch of the anterior division of internal iliac artery, but arises from the external iliac artery either directly or via the inferior epigastric artery in approximately 19% of the individuals. So B is the right answer. So let's move on to the anatomy of pelvis. I will again give you an overview, and then we will start practicing our SPAs from this topic. So the human pelvis is composed of the bony pelvis, pelvic cavity, pelvic floor, and the perineum. So here we have bony pelvis, pelvic cavity, and the pelvic floor. And the perineum we will discuss after once we are done with the pelvis. So I had some important bony landmarks of the pelvic brim. So pelvic brim marks the entry point of the true pelvis. Above the pelvic brim is the false cavity. Now let's have a look in the sequence. When we go from interior to the posterior, when we go posteriorly, let's see what are the bony landmarks which marks the pelvic brim or the entry of the pelvic cavity. So at this point, at number 1, we have upper border of symphysis pubis. Following that, at this point, we have pubic crest. Then here is the pubic tubercle. Then we have the pectineal line. This one is the pectineal line. Then we have iliopubic eminence. And then we have iliopectineal line. This one is the sacroiliac joint. Then we have anterior ala of the sacrum. And then this one is the anterior ala of the sacrum, and then sacral promontory. So remember these bony landmarks. Sometimes they ask you the SBA, like what bony landmarks are involved or mark the entry of the pelvis, true pelvis, or the pelvic brim. So make sure all these points form the pelvic brim. Then we have imported joints of the pelvis, including 2 sacral joints, sacroiliac joint, sacrococcygeal joint, and the symphysis pubis. So we have 4 joints of the pelvis. Sacroiliac joint is a synovial joint. The symphysis pubis is a secondary cartilaginous joint, and these both are frequently asked in the exam. Then we have some important ligaments of the pelvis. There are many ligaments, but these 3 ligaments are the main ligaments, which is sacrotuberous ligament, sacrospinous ligament, and iliolumbar ligament. Here you can see here is the sacrotuberous ligament, here is the sacrospinous ligament, and here is the iliolumbar ligament. And this ligament is important in supporting the lower lumbar spine. It plays an important role in restraining movement in the lumbosacral and sacroiliac joints. And this is also asked in the exam about the function or role of the iliolumbar ligament. Then we have some diameters of true pelvis. So the true pelvis have mainly 3 diameters: the anterior posterior diameter, oblique diameter, and transverse diameter. So mainly the pelvis, the true pelvis, is divided into inlet, which is also known as pelvic brim, which we have discussed recently. Then we have cavity, and we have outlet. So all these diameters vary accordingly. Like in the pelvic brim, they have different diameters. In the cavity, they have different diameters. And in the outlet, they have different diameters. So this one is the anterior posterior diameter. This one is the transverse, and this one is the oblique diameter. And this anterior posterior diameter, we have further, it have 3 conjugates. One is called anatomical conjugate, obstetric conjugate, and the diagonal conjugate. How we can differentiate? This is again the anterior posterior diameter, and in the anterior posterior diameter, we are further dividing that into 3 conjugates. So what is true conjugate? The anatomical or true conjugate measures between the sacral promontory and the upper edge of the pubic symphysis. Then in the obstetric conjugate, measures from the sacral promontory to the point bulging the most on the back of the symphysis. Then we have the diagonal conjugate, which marks from the sacral promontory to the lower edge of the symphysis pubis. So these 3 are the conjugates. And again, the values vary. The anterior, posterior, oblique, and transverse diameters vary according to their anatomical point. Either whenever you get a question, have a look. Either they are asking about at the level of pelvic brim, Either they're asking about the diameter in the cavity or the outlet. So answer your question accordingly. Then we have pelvic cavity. It is a space inside the pelvic bones.
Excuse me, ma'am. Can you
Yes.
kindly read the conjugates of anterior posterior diameter?
Yes, sure. Okay, so we are discussing about the true pelvis. True pelvis further have inlet, which is pelvic brim. Below that we have pelvic cavity, and below that we have pelvic outlet. There are three diameters of the pelvis. One is the anterior posterior, then we have the oblique, and then we have the transverse. This is the anterior posterior diameter. This one is a transverse, and this one is the oblique diameter. Out of these diameters, we particularly pick the anterior posterior diameter and discuss further about the conjugates. Please note, transverse and oblique diameters do not have conjugates. The anterior posterior diameter have three conjugates, which are true conjugate, obstetric conjugate, and diagonal conjugate. What is true conjugate? It marks the distance between sacral promontory. All of them have the common point, which is a sacral promontory. The difference is at the level of symphysis pubis. So when we measure the distance from sacral promontory up to the upper border of symphysis pubis, we call that as true conjugate. When we measure the sacral promontory from the point bulging behind the symphysis pubis is obstetric conjugate. When we measure the sacral promontory to the lower border of symphysis pubis, we called it as diagonal conjugate. Am I clear now?
Yes, ma'am. Thank you.
Okay. Now we have discussed the diameters of the pelvic cavity. Now have a look at the contents of the pelvic cavity. So the common contents, both in male and female, we have bladder, terminal sigmoid colon, rectum, descending colon, and distal ureters. In the females, the content of the pelvic cavity are uterus, fallopian tubes, ovaries, upper vagina, and cervix. In males, we have vas deferens, seminal vesicles, and the prostate. So these are the contents of the pelvic cavity, and the purpose why I'm telling you this information is to just make you oriented what you are actually studying from the pelvis or from the perineum or from the abdomen. So just have an idea what is the basics and what are the basic structures there, and what is the basic blood supply, nerve innervation, and the nervous system and the peripheral nervous system. So we have discussed bony pelvis, we have discussed pelvic cavity. Now let's have a look at pelvic floor. The muscles of the pelvic floor is mainly formed by the muscles. So what are the muscles of the pelvic floor? We have four muscles: pubococcygeus, iliococcygeus, coccygeus muscle, and the puborectalis muscle. So all these four muscles form the pelvic floor. Then we have levator ani muscle. Out of these muscles, puborectalis, iliococcygeus, and pubococcygeus, altogether these three forms the levator ani muscles. Why I highlighted the coccygeus muscle? Because there are two types of SBAs. One is a general SBA in which they just ask about the muscles involved forming the pelvic floor. And the other SBA in which they specifically ask about the muscles forming the levator ani. What mostly students do, they confuse the both SBAs, or they rushly solve the SBA and they don't focus on the question statement, and they miss a very simple SBA in that way. So make sure you study the statement carefully, read the options carefully, and go and find the correct answer. So again, if they are asking about in general muscles of the pelvic floor, you may include coccygeus. But if they are asking particularly about levator ani muscle, exclude coccygeus from the options. Am I clear?
Yes, you are.
Okay. So let's start the SBS from the pelvic cavity or the pelvis. Which artery supplies the distal portion of the round ligament of the uterus? Okay, Dr. Hassan, why did you go with the option B?
As I remember, the round ligament, it gets applied from a special branch. It's called Samson artery, which is branch of ovarian artery. But
Okay.
I guess because they describe exactly for distal portion of round ligament, which I think it's so close to the uterine. So I select the uterine. But maybe I'm wrong, I'm not sure.
Okay. Initially, you were talking right. The round ligament is supplied by the Samson artery, but you were wrong because Samson artery is a branch of inferior epigastric artery. So you were partially right and partially wrong. Let me clear. The artery of the round ligament of the uterus is also known as Samson's artery, is a branch of inferior epigastric artery. And the thing you were talking about, the uterine artery and the ovarian artery, yes, together, uterine artery, they get anastomosed with the Samson artery. However, just remember the main arterial supply, which is inferior epigastric artery. Are you clear now?
It's clear, thank you. Yeah, of course. Thank you.
Perfect. So which nerve or nerve plexus provide a sensory innervation to the cervix? Okay, well done, everyone. C is the right answer. The pelvic splanchnic nerve are ganglionic parasympathetic nerve fibers that arise from the S2, S3, and S4 nerve roots of the sacral plexus. These nerves form the parasympathetic portion of the autonomic nervous system in the pelvis. So C is the right answer. Well done. What type of joint is formed at the sacroiliac joint? Okay, Dr. Minan Mustafa, why did you go with the option B? I know the answer. Why did you choose the option B? But I want to hear from you. I know your mistake. Dr. Minan, are you there? Okay, the answer is E, synovial joint. Sacroiliac joint, which is also known as SI joint, is diarthrodial synovial joint. It is surrounded by a fibrous capsule containing a joint space filled with synovial fluid between the articular surface. Yes, you confuse this with symphysis pubis. That is secondary cartilaginous joint. But SI joint, it is synovial joint. More specifically, diarthrodial synovial joint. Okay, which of the following gives the correct pathway of piriformis muscle, origin, exit, pelvis, and insertion? Okay, well done. A is the right answer. The piriformis muscle originates from the anterior sacrum and the sacroiliac joint, passes to the greater sciatic foramen and insert into greater trochanter. Here you can see it is obvious if we see from the lateral view, it is not coming from the ventral surface. It is not coming from the posterior aspect, from the dorsal surface. It is entirely coming from the ventral surface of the sacrum and inserting onto the greater trochanter of the femur, and it is passing through the greater sciatic foramen or greater sciatic notch. Okay, the next question is the ovaries receive innervation from which spinal segment? Okay, yes, A is the right answer. There are two contributions of the ovaries, one from the sympathetic and the other one from the parasympathetic. The sympathetic contribution is mainly through greater and lesser thoracic symplectic nerve, which is T10 and T11. And the parasympathetic comes from S2, S3, and S4. The nerve, which follows the course of ovarian artery to reach the pelvis. A sympathetic supply to the ovary, distal uterine tube, and the uterine fundus. whereas the parasympathetic supply again to the ovary, distal uterine tube, and the uterine fundus. Am I clear?
Yes, ma'am, you are clear.
Which of the following ligaments allow us to stand upright with a minimum of muscular support? Okay, D. Iliofemoral is the right answer. This ligament plays a crucial role in stabilizing the pelvis and allowing us to stand upright with a minimal muscular effort. It helps to support the sacrum and the coccyx, thereby contributing to the stability of the pelvic girdle and the spine. Here you can see the iliofemoral ligament. Which of the following muscles leave the lesser pelvis through the greater sciatic foramen? Yes, D is the right answer. We have just discussed this SBA in a different way. So piriformis muscle, it leaves the pelvis through the greater sciatic foramen. Okay, when the body is in upright position, the expected angle between the brim of the pelvis to the horizontal plane is approximately. Dr. Saima, basically artery and vein. Basically, we cover this under the contents of greater sciatic foramen and the lesser sciatic foramen. So basically the piriformis muscle, it is a muscle which mainly plays a role in forming the greater and the lesser sciatic foramen. And above the piriformis, we divide further what contents are passing above the piriformis muscle and below the piriformis muscle in the greater sciatic foramen. And then we have the different contents, different arteries, veins, and nerve, which pass through the lesser sciatic foramen.
Thanks, ma'am.
Okay, excellent. C is the right answer. The standing position, the plane of the pelvic brim to inlet creates an angle between 50 to 60 degrees with the horizontal plane. Okay, the lymphatics of the sigmoid colon drain into. Well done. C is the right answer. The descending colon and sigmoid colon drain into the inferior mesenteric nodes, and the lymph nodes surrounding the inferior mesenteric nodes artery drain directly into pre-aortic nodes. So C is the right answer, which is inferior mesenteric and pre-aortic lymph nodes. Okay, what is the blood supply of the sigmoid colon? Yes, C is the right answer. Well done again. As the sigmoid colon develops as a hindgut structure, it receives its blood supply from the inferior mesenteric artery and in specific sigmoidal branches. So please tell me, what is the vertebral level of inferior mesenteric artery?
L3.
Yes, that's correct. Inferior mesenteric artery originates at the level of L3. That's correct. So let's start the anatomy of perineum. The perineum basically can be divided into two triangular portions by the line between the ischial tuberosities. Here you can see the anterior portion is called the urogenital triangle, and the posterior portion is known as the anal triangle. So here you can see the anterior portion, this is the urogenital triangle, and whereas this portion, which is the posterior portion, is known as anal triangle. The anal orifice can be appreciated in the anal triangle, while the respective external genitalia occupy the urogenital triangle of the either sex. In the perineum, I have added some of the important topics, these are the high yield topics from the perineum, which is ischiorectal fossa or ischioanal fossa, and I have also added the pudendal canal. So what is ischioanal fossa? The anal canal is present in the middle of the anorectal triangle, and on each side is the ischioanal fossa. So here is the anal canal, and on each side we have this fossa, which is ischiorectal fossa. The ischioanal fossa is limited and comprised of the following structures. So these are the boundaries. Medially, this ischiorectal, if you see the diagram and appreciate the boundaries of this fossa, if you look at the medial side, it is formed by the external anal sphincter. And on the lateral side, it is formed by the obturator internus muscle and its fascia. And the roof is formed by the levator ani muscle. And the base is mainly formed by the skin. And the space between the borders filled with loose adipose tissue. So here in the yellow color are the adipose tissues. Again, here you can see this is in the highlighted area, this is the ischioanal fossa. Again, it have lateral boundary, which is formed by the obturator internus muscle and fascia. And it have medial boundary, which is mainly formed by the external anal sphincters. Here we have adipose tissue, which are filled, and its roof is formed by the levator ani muscle, and the base is formed by the skin. So this is all about the ischioanal fossa. And if you look at closely, here we have the pudendal canal. Let me show you the slide. The pudendal canal is also known as Alcock's canal, is an anatomical structure in the pelvis through which internal pudendal artery, internal pudendal vein, and the pudendal nerve and nerve to obturator nerve pass. Again, here you have pudendal canal, which is also known as Alcock's canal. And here you can appreciate the contents of this canal, which are mainly, please remember, it is internal pudendal artery and internal pudendal vein and the pudendal nerve. These are the branches. I have added this algorithm of the branches of the internal iliac artery so that later on, whenever you are studying and solving SPAs, you can have a look and easily solve your SPAs. And here are the branches of external iliac artery. If you study the algorithms, it is very easy to remember the branches of any of the artery.
Please, previous slide.
This one?
Internal, the previous one.
Yes, ma'am.
This one?
Yes, yes. Thank you.
Okay. Okay, let me read this for you. So we know we have common iliac artery, which bifurcates at the into external iliac artery and the internal iliac artery at the level of L5 to S1. And this internal iliac artery gives further branches, mainly the superior vesical artery, obturator artery, inferior vesical artery. Then we have middle rectal artery, internal pudendal artery, and superior and inferior gluteal arteries. So these are the branches of internal iliac artery. And here is the area of supply, like where these arteries are supplying to which structures. Likewise, we have algorithm of external iliac artery and the area they are supplying. If we look at the external iliac artery, it gives femoral artery, which moving downwards and give popliteal artery. This popliteal artery further divides into anterior tibial, posterior tibial, and then fibular. And from posterior tibial, it gives a peroneal branch, and the anterior tibial and posterior together form the dorsalis pedis artery, dorsal arch, and plantar arch. However, for this exam, there is no need to study about the blood supply of the lower limb. Just focus on the blood supply of the structures which are mainly located in the abdomen, pelvis, and the perineum. Okay, some SPS come from the fetal skull as well. So when we look at the anatomy or the bony structures of the fetal skull, we have 2 frontal bones, 2 parietal bones, and 1 occipital bone. And many questions come from the formation of sutures. So there are 3 main sutures you need to remember: the coronal suture, sagittal suture, and the lambdoid suture. How the coronal suture is formed. Here you can see this is a coronal suture. This one is a sagittal suture, and this one is a lambdoid suture. So a coronal suture forms by each frontal bone plate meets with the parietal bone plate at the coronal suture. Then sagittal suture, this extends from the front of the head to the back, down to the middle of the top of head. The 2 parietal bones plates meet at the sagittal suture. The lambdoid suture extends across the back of the head. Each parietal bone plate meets the occipital bone plate at the lambdoid suture. So just remember these points. Many SPS come from this topic. Okay, let's solve some SPS from the perineum. Which of the following structures separate the superficial perineal pouch from the deep perineal pouch? Yes, D and E both have the same options. In the exam, it happened with me. There are 2 questions which have 2 correct options. And there were 2 questions which are repeated in the exam. I'm talking about my exam experience. So if you find in the exam that 2 correct options are there, like for example, in this question, then don't get panicked. If you choose D, you will get a mark. If you choose E, then again, you will get a mark. And if the questions are repeating, for example, if this question, you solve that question and it was question number 1, and question number 10 again come, which have the same question, then definitely you will get the marks from both questions if you solve them correctly. Okay, so D or E, either you go with the D or E, that's the same thing. So the perineal membrane is a dense fibrotic layer situated over the urogenital triangle. In both sexes, the urogenital triangle is divided into superficial and a deep perineal space by the perineal membrane. So this transparent layer, this is the perineal membrane, and it divides the superficial and deep perineal pouch. Okay, which of the following arteries give rise to the deep dorsal penile artery? A is the correct answer. Well done. Deep dorsal penile artery is a branch of internal pudendal artery. In this diagram, it is all about the blood supply of the penis. So here you can see how the internal pudendal artery give rise to further arteries, including the dorsal artery, dorsal penile artery, cavernous artery, and it is also supplying the corpus cavernosum, and also it is giving the smaller branches to the glans penis. Okay, the bifurcation of the abdominal aorta occurs at the level of which of the following structures? Excellent. B is the right answer. The aortic bifurcation is usually seen at the level of L4, just above the junction of left and right common iliac veins. The aortic bifurcation can be localized not only by its usual position in relation to L4, but also by its relation to the iliac crest. So here you can see this is the highest point of iliac crest, and at this level, the bifurcation, this is the level L4, and how you can see how it is bifurcating at this level. Which of the following describes the correct order of musculature of the anal canal from deep to superficial? Arrange these followings: deep part of external sphincter, subcutaneous part of external sphincter, internal sphincter, and superficial part of external sphincter. Arrange these in the correct order. Dr. Lisa, we will cover 30 SBS today, so 5 more to go. Okay, well done. C is the right answer. Let me show you how we arrange them. Deep to superficial, we have internal sphincter, deep part of external sphincter, superficial part of external sphincter, then we have subcutaneous part of external sphincter. Now, let me show you how we go from deep to superficial. So here we have first internal sphincter, Then we have different parts of external sphincter, including, if we go in the sequence, we have deep part, then we have superficial part, then we have subcutaneous part. So this is how we arrange them from deep to superficial level. And please always make sure either they are asking from deep to superficial or superficial to deep. In that case, you have to reverse the order. Okay, which of the following arteries supplies the anorectal canal superior to the pectinate line? Perfect. C is the right answer. Okay, what happens? We got two types of question from the blood supply of anorectal canal. Either they ask you about the above pectinate line, or they may ask you below pectinate line. So, or they may use the word superior to third or inferior to 1/3. So don't confuse these terms. So the above pectinate line, the arterial supply is through superior rectal artery, which is a branch of inferior mesenteric artery. If we look at the below pectinate line or inferior 1/3 of the anal canal, then it is supplied by the middle and inferior rectal artery, and inferior rectal artery is a branch of internal pudendal artery. Okay, an obstetrician performs a medial lateral episiotomy to expand the birth canal during the childbirth. Which of the following muscles is typically incised during this procedure? Okay, perfect. A is the right answer. The structures cut during episiotomy are skin, subcutaneous tissue, perineal fascia, perineal muscles, bulbospinges, and the branches of pudendal vessel, and the nerves and posterior vaginal wall. So I have a question: which nerve damaged during the episiotomy? Which nerve is at the risk of damage during medial episiotomy? Excellent. Dr. Lisa, Dr. Ashi, and Dr. Ashim, well done. Okay, Dr. Aisha, the previous answer about, okay, the blood supply of the anorectal canal, we usually divide it by above pectinate line and below pectinate line. So above pectinate line is supplied by the branch of inferior mesenteric artery through superior rectal artery. Whereas below the pectinate line, it is supplied by the branch of internal pudendal artery. Am I clear now? Okay. Okay, Okay, what forms the lateral wall of the ischiorectal fossa? And don't worry, if we have time in the end, I will review those questions which some of you have missed. I think someone have missed question number 23 and someone missed question number 15, I guess. Okay, sure, Dr. Sarish. If we have time in the end, then definitely I will go back to those questions. Okay, well done. C is the right answer. Ischiorectal fossa are laterally bounded by the obturator internus muscle and its fascia. Here again in this diagram, again learn this topic comes frequently in the exam, so understand its relations. Laterally obturator internus muscle and its fascia, medially by the external sphincter, and it has the roof is formed by the levator ani muscle. A 30-year-old para 1 plus 0 woman presents with painful swelling in the right posterolateral part of vagina and fever for 3 days. Diagnosis of Bartholin's abscess is made. Incision and drainage is planned. What is the anatomical location of Bartholin gland? Excellently is the right answer. The Bartholin glands are located within the superficial perineal pouch of the urogenital triangle. What is superficial perineal pouch? It is a potential space between the perineal membrane superiorly and the superficial perineal fascia inferiorly. The other contents of the superficial perineal pouch are erectile tissues that forms the penis and the clitoris, 3 muscles including ischiochoanosis, bulbospongiosus, and superficial transverse perineal muscles. So all these are the contents of superficial perineal pouch, including the Bartholin gland. A 35-year-old diabetic woman underwent vaginal surgery. Post-op, she has loss of cutaneous sensation over the interior and lateral surface of the thigh, the compression of which nerve is likely to be responsible. Yes, B is the right answer. How it is the right answer? The lateral femoral cutaneous nerve, also referred as lateral cutaneous nerve of thigh, is formed by the spinal nerves L2, L3. In the thigh, the lateral femoral cutaneous nerves gives two branches, the anterior branch and the posterior branch. And this anterior branch supplies the skin of anterolateral thigh to the knee, and the posterior branch innervates the skin to the lateral aspect of the greater trochanter, to the mid-thigh region, and sometimes to the gluteal region as well. And in this particular scenario, the patient has loss of cutaneous sensation over the interior and lateral surface of the thigh, which is a classical innervated area by the lateral femoral cutaneous nerve of thigh. Here in this diagram, again, it is highlighting the area which is affected by the lateral cutaneous nerve of thigh. Am I audible to everyone?
I'm hearing you.
Okay. Okay, are you clear about the innervation of lateral cutaneous nerve of thigh?
Yeah.
Okay, so if anyone have any question, you can ask me.
Would it be possible for you to go back through the question where we were discussing these nurse supply?
Yes, definitely. Which particular question you are requesting me to repeat?
I'm not sure which number it was, but it was the question related to the nurse supply of the survey.
Okay, if you remember any key point, I can go back to the slides and find that question for you. Okay, Dr. Serge, 1, 2, 3, and 23. Okay, so yes, this video would be uploaded on our website. You can later on watch there. Okay, so the question one was, while performing laparoscopy, the lateral umbilical folds can be seen on the anterior abdominal wall in the adults. This structure contains okay, so mainly contains, where is that slide? On the slide. Okay, here we have the structure it contains is the inferior epigastric vessel. The lateral umbilical folds are basically bilateral raised ridges of the parietal peritoneum in the deep aspect of the interior abdominal wall overlying the inferior epigastric vessel. Are you clear? Okay, so the second question is, which vessels can possibly be injured in the subcutaneous tissue when a transverse suprapubic skin incision is made? Okay, so the answer is superficial epigastric artery. It is a branch of femoral artery and runs obliquely upwards and medially across the lower abdomen. It supplies blood to the skin subcutaneous tissue of the lower abdominal wall below the umbilicus. Dr. Ruby, this SP is for you. You were asking this question. This artery can be encountered during a transverse suprapubic skin incision. Which structure blocks a blood supply to the loop of small intestine and femoral ring, causing strangulated femoral hernia? Yes, B is the right answer, lacunar ligament. Lacunar ligament is the only boundary of the femoral canal that can be cut during the surgery to release femoral hernia. And sometimes it happens, femoral hernia is at high risk of getting strangulated. So there are many chances that if someone has femoral hernia, that might get strangulated later on. So strangulation is compression of the hernia, which has compromised the blood supply, leading to the bowel becoming ischemic. So that's another complication if a person has femoral hernia and ultimately he or she had the strangulation of that hernia, that ultimately leads to the bowel ischemia. So that's why whenever we are performing the surgery of femoral hernia, what we usually do, we release the lacunar ligament and help to reduce the chances of the bowel ischemia, as well as we reduce the femoral hernia as well. And what artery is responsible for this bowel ischemia is the inferior epigastric artery. So these are the high yields points from this topic. Am I clear to everyone? Okay, so someone asked me to repeat question number 23 as well.
Hi, Dr. Sumbal. A gentle reminder, you have another session.
Okay, thank you so much for reminding me.
Can we WhatsApp it?
Yes. Okay, so everyone, thank you so much for actively participating with us. So what I would suggest you now to speed up your exam preparation, because you have very limited time, and don't spend too much time on reading theory, and try to do your preparation in a focused and strategic way. And if any time you need our help, our assistance, me and my team, we all at Med Institutors are here for your help. You can contact us anytime. And if, because we have a limited time right now, so post all of your questions on our Telegram group or on the WhatsApp group. I will try to reply everyone at my earliest convenience. Goodbye, everyone. See you in the next live session. Goodbye.
Bye. Thank you.
Welcome.